my name is Dr. Ellie Worthington and I work for Hammersmith and Fulham Training Hub, and this webinar series comes to you funded by Supported Return to Training, which is a Health Education England initiative. We are looking today at managing COVID, your patients and you, which is the first part of a three-part series of returning to work in general practice post-pandemic. So COVID is a new clinical entity for all of us working in clinical practice. It's not one that we'll have learnt about in medical school. It represents a very new disease, and as time has gone on and we've learnt more about it, we've understood that it has a very specific disease course of its own, and helpfully there are some predictable features that help us to identify COVID itself, as well as being able to predict who might become more unwell with COVID. So today I'm going to look at the disease course in general over time, to look at risk factors and mortality rates, to look at clinical management and how we can manage these patients from primary care. We will have a quick look at long COVID, and then a very brief word about testing. So in terms of the actual disease course of COVID, you'll find that there's two main responses that the body makes. One is the general viral response that you would have to any virus. So you get the aches and pains, the fever, any kind of constitutional symptoms that you might normally associate with viral illness. And that's early on in the first week. And then as time goes on, and particularly around days kind of 7 to 10, sometimes people enter an inflammatory phase of COVID. And this is what can cause some of the more serious complications, particularly affecting the lungs with COVID pneumonitis. It's also a hypercoagulable state. And so there's a higher incidence of clotting and pulmonary embolism. And it's also thought that it's probably the inflammatory response that's responsible for some of the ongoing prolonged long COVID symptoms, although this is not yet fully known. Ultimately, COVID can lead to multi-system inflammatory response, and that's what obviously leads people into intensive care and needing all sorts of support, particularly for their lung function. We know that the critical time period, as I said, is usually between the end of the first week, so days 5 to 10. That's when we often see people deteriorating, and so that's a figure that you should keep in your minds whenever you're taking a history from someone who has COVID. In terms of risk factors, the initial, as you might know, the initial shielding letters that went out were very much based on people who were known to be on immunomodulatory drugs, typically chemotherapy or drugs for biological drugs or any kind of immunosuppressants. And these were the ones who were initially shielded during the pandemic. But as time went on, it became evident that there were a number of other risk factors that weren't necessarily taken into account, and particularly a predominance for males. So 65% of those dying from COVID were male. And age is a particularly critical factor, and 90% of deaths in COVID are in the over 60-year-olds. And then we also realised that it was disproportionately affecting those who were obese, so with a BMI over 30, and the Black and minority ethnic groups were also being disproportionately affected. And so actually having potentially some younger Asian male diabetic patients, they may be at high risk of COVID complications and mortality compared to female white counterparts, for example. So it's important to know who it is that is catching COVID, because the context of the patient and any underlying conditions or their general data can affect how unwell they may become, and you might want to have a higher threshold of risk, safety and assessment for those who have any of the following risk factors. So in terms of a GP in primary care, and if you have a patient presenting to you who has possible COVID symptoms, what is it that we need to know from the history? Well, as I mentioned before, there's obviously the general viral typical symptoms that people will tell you about, and most specific to COVID are the dry, continuous cough, and then the loss of smell and taste, as well as a fever, which is defined as having to be over 38 degrees Celsius. And those are the three commonest features that we see, but there are a whole host of other viral symptoms that can come along, like headache or diarrhea or skin changes, but these are less specific to COVID. So important in your history taking is to find out about breathlessness. And this is because, as I mentioned, part of the COVID inflammatory response can be to affect the lungs. And so you always want to know whether somebody is feeling more breathless than usual, and particularly on exertion. So whether they are finding that moving around the house, going up and down the stairs, getting up to go to the loo is causing them to feel either more breathless or more fatigued. And the reason this is important is because there's a potential for silent hypoxia. So patients who actually have low levels of blood oxygen, but they're not necessarily aware of it. And this is often most experienced on exertion. And so this would indicate potential deterioration or complication, and I would say should always be reviewed if anyone's got exertional symptoms. Any viral symptom, however, as I've said, can be a symptom of COVID. And you would also want to think about what impact it's having on someone's daily life. So in terms of, are they literally kind of bed bound because they're feeling so unwell, they're so tired that they're not actually able to get up and cook a meal or sit out in the lounge, for example. So finding out how much it's affected someone, again, is a really helpful indicator of firstly whether they're getting better or worse if you compare them from one day to the next, but also of just how unwell they are with this virus. It's critical to know when their symptoms first started, and also if they've had a COVID test, which should now be readily available. Patients can ring 119 and organise to go to a test centre. It is possible to get them sent to your house as well if you have no way of getting out. The reason it's really important to know the dates is that it's crucial for the isolation period. So obviously somebody who's, as we know, can be asymptomatic with COVID, they need to isolate from their positive test date, whereas the symptom onset date is really helpful from a clinician's point of view, as I mentioned before, in terms of knowing the point of deterioration. So if someone is around day 5, 7, 10, and they're starting to feel exertional breathlessness, for example, you're going to be thinking, could this person have developed pneumonitis? May they have an underlying PE? I think they need to be assessed and have at least their oxygen saturations measured. Other important things to think about are the household contacts. Obviously, public health messaging, people should know that the whole household needs to isolate for the 10-day period, but it's still worthwhile just checking that people are aware of that. And also we found, particularly in the second wave of COVID and with the new variants, that whole households were being affected. So whereas in the first time round it seemed like you could, if you caught COVID, you could go to your room and hibernate, and other members of your household would be okay. And the second time around, we found that it was often the whole family and the whole household were also unwell, even if to varying degrees of severity. And then finally, as I mentioned before, just understanding who is the patient that you're talking to. Obviously, how old are they? What are their underlying conditions? What's their ethnicity? Do they have any other reasons to suspect that they could become more unwell with COVID? And so this is all part of your risk assessment. Is this likely to be COVID? And if so, is this person likely to become really unwell? In terms of examination, obviously we are now doing a lot more remotely in primary care. I would say that for somebody you're concerned about with possible COVID, it's always a good idea to do a video call if at all possible, rather than telephone, just because you can get so much more information if you're visualizing someone and able to see them interacting with you, as well as there are obviously some examinations that you can do over video, albeit that they may not be quite as accurate. For example, you can attempt to count their respiratory rate and see whether there's an increased work of breathing. In terms of patient equipment, we are seeing lots of people have now bought their own pulse oximeters. Many would have had blood pressure machines, for example, before the pandemic, but even more now have their own thermometers, pulse oximeters, BP machines. So it's always worthwhile asking the patient, do they have a set of obs that they can give you? If they haven't done one that day, then obviously you can get them to repeat that there and then. But it's a really helpful guide, knowing if someone is febrile, tachycardic, you're obviously going to be more concerned than if all of their obs are normal. Specifically focusing on the respiratory system, like I've mentioned, to see whether there is any sign of respiratory distress. We also need to measure their we also need to examine for desaturation if they do have their own pulse oximeter. And so the standardized way of doing this is either with a sit to stand test for 1 minute, which involves getting the patient to stand up and sit down, up and down out of their chair for 1 minute, and you're looking for a more than 3% drop in their oxygen saturations that would count as a significant exertional desaturation. Obviously, it's really important that we don't that we're safe when we're doing this, particularly if we are remotely assessing someone. And so anyone who has SATs of 93 and below, you should not do this from home. And I would suggest that it's not really safe at all below 92% because of the huge risk of desaturation. We also know that the pulse oximeter is less reliable on darker skin, and I think there's thought to be a 1 or 2% variation if they've got darker skin. Acrylic nails, cold hands also give false readings, as does atrial fibrillation. So obviously none of this assessment is completely as reliable as whether you were doing it face to face with somebody. However, it's better than nothing, and you can always ask them to show you the probe on their finger. You might then be able to get an idea whether there's an accurate tracing on the machine, and whether the numbers are skipping around lows, which obviously might indicate AF, or whether there looks like there's a consistent trace. So it's best to get this information if you can, but obviously if there's any doubt or you're not sure if it's reliable or not, then the next best thing is to see them face to face. Lastly, as I mentioned, there is this phenomena of silent hypoxia, so it's always worth asking someone for their oxygen level if they've got the machine, even if they're not feeling breathless. And there are, obviously this will vary from patch to patch, but there are lots of initiatives locally where patients are able to get oxygen probes delivered from a central point, and that will obviously help you in your either initial assessment or ongoing monitoring of patients. So these are from the at the time of recording, the latest version, which was version 8 of the North West London COVID respiratory guidelines. And this is the algorithm that's used in lots of the community hot hub areas to essentially triage how unwell patients with suspected COVID are. And as you can see, it's a traffic light system. Over on the left, you have those who have the milder category 3 symptoms. So these would have saturations of 94% or higher. They would have a normal respiratory rate, a normal heart rate, and a low NEWS2 score. And these are the group really that, as long as they don't have any terrible risk factors, you could usually just get them to stay at home and give them safety netting. If you were worried that they could deteriorate because of their risk factors, then it would be more than appropriate to get them monitored. And there are, I'll talk about that a bit more, but there are different initiatives that are set up to help monitor stable COVID patients with mild symptoms, but who are at higher risk of deterioration. And then if we move over to the right, we've got the kind of the red flags. So those who are much more obviously unwell, they've got obvious signs of sepsis, and the cutoff for the SATs here is 92% or lower, obviously taking into account those who might have chronic hypoxia. But anyone who's got a respiratory rate over 25, a heart rate over 130. And these are the ones that it's much more obvious. They just need to go to hospital because they need to have a full assessment, blood test, chest x-ray, and potentially admitted for ongoing support. So I think the trickier group for us as GPs is the middle group, which is the moderate symptoms. And these are subdivided into category 2A and 2B. So the 2Bs are the housebound. So these are the ones that or they're very high risk in terms of their risk factors. So you may feel that they definitely need a home visit. And again, usually us as GPs are now doing this kind of visit, or you might be able to get your local rapid response team to help. But it's the 2As who have given us some clinical uncertainty about what the right thing to do with them. Obviously, as we have been during the height of the pandemic, trying to avoid any unnecessary admission, whilst also wanting to keep a close eye on those who are at risk of deteriorating further. And so these people may describe exertional symptoms, like I mentioned, either feeling dizzy or tired or breathless on exertion. They may have obvious signs of chest tightness or wheeze, but this is the group who are saturating between 93 and 94%. And these are the group who, if it's 94%, you can do your exertional SATs measure to see whether there's a drop. But really we can get them to come and be assessed face to face ideally, and this is what your local hot hubs have been set up to do. I know that these are not working in every area, but there are lots of them in Northwest London where we're recording this from, and it's designed to bring in patients who are suspected to be infected with COVID, to see them face to face, to do a desaturation test, and to really assess their clinical need to either go to hospital or whether they're going to be safe to stay at home with very careful remote monitoring. And these patients often get given their own SATs probes to take home, and they can either give their daily data via an app called MeadowPad or through AccuRx text messaging systems, depending on their IT capability. If they have absolutely no IT capability, then they can get daily phone calls. So this was the general pattern during the height of the surge. Obviously, now at the time of recording this, things are thankfully starting to improve again in terms of the numbers. And so hopefully this information won't be needed again, but just in case, that's what we've been doing. So in terms of options for management, I have covered some of those as I talked through the algorithm there, but essentially you're trying to categorize people as those who might be safe to have to just monitor themselves. So those that you trust to monitor their own symptoms, their own energy, and potentially their own oxygen if they've got access to a machine. There's an excellent safety netting guide that NHS England has produced, and I send that to all of my patients. And then there are some who, as we've said, will need a face-to-face review. It's just either impossible to properly feel confident remotely that they are safe. You want to get an accurate set of observations, so they need to be assessed. And if they've got COVID symptoms, then we've been trying to send them only to the hot sites, which is the hubs, and keep general practice as a cold site. As mentioned, it will be totally appropriate to call 9994 because they need to go straight to A&E and have a full acute assessment. And then there are those who have been felt stable enough to keep in the community, but they're going to have admission to the COVID virtual ward. One of the platforms, as I mentioned, is called MeadowPad, and that's where they are basically monitored daily until they're felt deemed to be safe enough to discharge. We have also been asked in primary care to identify anyone who tests positive for COVID to be assessed in their clinical context as to whether they have the potential to deteriorate. So looking at their risk factors, as I mentioned already. And even if they've only got mild symptoms or possibly they're only asymptomatic, if they've got risk factors that mean they're higher risk of deterioration, they should also be referred to the virtual wards for ongoing monitoring. Just a couple of thoughts about definitions. So NICE guidelines have detailed the following for the time periods associated with COVID. So you have the acute phase, which is under 4 weeks, although most people will recover within 1 to 2 weeks. Ongoing symptomatic COVID is between 4 and 12 weeks. And then once you go over 3 months, it's post-COVID syndrome. And then rather confusingly, long COVID covers both the previous categories. So anyone who's got COVID over 4 weeks, essentially, as well as those who are going into the months and months of suffering. Just a quick thought again about long COVID. I've written the estimated prevalence is about 10%. I have also subsequently read that it's thought even as much as 1 in 4 could suffer from long COVID, but obviously this is very dependent on what definition you're using in terms of symptoms. And so it's thought around 10% for those who go on over 3 months to still be having symptoms of COVID. Critically, the symptoms, particularly as a GP, it's important that we know this, the symptoms are varying, relapsing and multi-system. So there's a whole host of different systemic effects that patients might be suffering from. And this is why it can be quite a tricky clinical entity to manage, particularly trying to identify what is a side effect or complication of COVID and what actually might represent a new presentation. For example, palpitations, trying to understand whether these are part of a long COVID syndrome or whether these are something that need investigating as any new cardiological symptom might warrant. We don't know yet whether COVID is going to affect people for months, years, or potentially be lifelong. We just don't know what this disease is going to do. And obviously that leads to a lot of uncertainty for patients, as well as for us as clinicians, not being sure what kind of encouragement we can give people in terms of expectations for recovery. Certainly, if anyone's had a severe pneumonitis or been in hospital, they need to know that it's going to take months before they feel fully back to their normal strength. And it can be expected if you've had a pneumonia, it's usually takes at least 3 months before you feel back to normal. Interestingly, there doesn't seem to be a connection between those who have higher risk factors for developing COVID or who have risk factors for more serious COVID and the disease severity that you end up getting. So those who end up with long COVID may have just had a mild disease course. There are a lot who are previously fit and well and not necessarily from ethnic backgrounds that carry higher risk. And so again, there's a kind of disparity between who ends up suffering for the longest time. I've put the website up there for Your COVID Recovery, which the NHS is hosting, and that's a really useful site to signpost patients to, which outlines lots of the various symptoms and ways that they can try and manage some of these. One of the biggest pieces of advice is pacing, so gradual graded increase of exercise as tolerated, going slowly and steady, and allowing for relapses. which can be very discouraging as a patient. I won't go through all of these, but there are basically a lot of symptoms that can manifest as part of long COVID, and it's worthwhile familiarising yourself with these, because, as I said, part of our role as GPs will be to unpick what is felt to be COVID related and what might represent another disease or pre-existing disease, for example. And there are as time is going on, there are more and more long COVID clinics being set up, as well as more understanding and pathways for how to manage these. At 12 weeks after hospital admission, most patients need to have a repeat chest X-ray to check whether their chest signs have resolved, and there will be other interventions like that that become more and more standardised. Just a very quick thought about children in COVID is that generally children don't seem to catch COVID as easily as adults, so there's a lower incidence, and the majority of them will be asymptomatic carriers or just have mild symptoms. But it's worth knowing that we have seen a rare but clinically significant condition, which is known as PIMS, pediatric multisystem inflammatory syndrome, which is essentially an acute systemic inflammatory response. And I think the key thing to look for as GPs is any child who seems to be more unwell than you might otherwise expect. And one of the key features in PIMS is a continuous high temperature for more than a few days. Typically, this can present similarly to Kawasaki disease, so you sometimes get desquamation of the palms and soles, as well as conjunctivitis, red eyes. It's also quite common to get unexplained abdominal pain and GI symptoms as part of this. But essentially, with your GP hat on, look for any child who just seems sicker than you might expect if compared to whether they just had a viral illness. And these obviously need to go straight to A&E. They can end up needing a lot of inotropic support, and they can end up needing ventilation support, and so they can become unwell very quickly. So I would always have, if you're suspecting PIMS, call an ambulance and get them sent straight to A&E. And then finally, in terms of the COVID presentation, just in terms of testing, and again, this is a movable feast as things evolve quickly, but we know that obviously all healthcare workers and lots of other frontline workers are doing lateral flow testing, and so this is usually twice a week, and it's done to identify essentially whether you need a PCR test or not, because lateral flow tests are not as reliable, and there can be a lot of false positives and negatives, so the gold standard would still be PCR. They are both antigen tests, but obviously neither lateral flow or PCR are 100% reliable, and so we know that you still need to have the general infection control precautions, even with negative tests, and not get false confidence in those instances. Antibody tests don't tend to be done. They only have a very limited use, and so the mainstay that we are using is antigen testing. Just a note that PCR tests can remain positive for 90 days after initial infectivity, and therefore it's important not to retest with PCR within the 90-day period unless somebody presents with new COVID symptoms, as if they may be reinfected, which unfortunately is possible. We also know lots of known unknowns that sometimes I think it's just helpful to outline, but as I've mentioned, we don't know how long viral replication continues. Even if you are post-infectious, you may still be having viral replication and therefore have this positive PCR test. We don't know when that stops. We don't know how long antibodies remain and whether or not they actually confer immunity, which is partly why it's not a helpful test for us. We don't know how many times you can catch COVID, but certainly there are some unfortunate individuals who've had all of the different variants, or have had the same one, it seems, twice. And we also don't know, even though evidence is increasing, how much the vaccine protects against COVID, and hence, unfortunately, all of the infection control measures are still in place, because nothing is felt to be 100% safe. So that's the end of the clinical part, and we just wanted to have a think about how do we apply this knowledge through a case discussion. So I'll just tell you about this patient, and then we can think through some of the factors that might be important and helpful to think about as you seek to manage these kinds of patients in primary care. So this is Christine Taylor calling up about her husband Barry. He is 65 with type 2 diabetes. He's obese with a BMI of 40, and he's also a smoker. And I'll stop there and just say that obviously that puts him in a clinical context of being someone who is high risk for developing complications of COVID, his age, his diabetes, his obesity, and obviously as a smoker, we don't know whether he's got COPD, but this could affect his underlying lung function. So his acute history is that he's had 3 days of cough, of breathlessness, and possibly a fever. They haven't measured it, but he was feeling shivery a few days ago. And perhaps more concerningly, he's struggling to get up the stairs at home. He's lost his appetite and is feeling very fatigued. And so right there, I would already have heightened alert for this man because of the history of exertional symptoms and fatigue. He's only day 3. So he's still fairly early on in the trajectory. It may still just be the viral phase of the illness, but we would be concerned here about kind of looming inflammatory response. So his wife, Christine, is a receptionist. She's still going into work 3 days a week. She's felt tired and a bit nauseous with headaches, but she's not had any other symptoms. So the key questions here are, how will you assess Barry? How will we manage his condition, and what advice are we going to give to his wife, Christine? So I would suggest that in terms of options for assessment, obviously you're going to initially start off remotely because that's what is appropriate given that he has got definite COVID symptoms. We want to know whether he's had a COVID test or not, and if so, when that came back as positive. And if he hasn't, then I'm going to be suggesting that he gets one. In terms of his history that he gave us, as I mentioned, the exertional symptoms are concerning. And so I'm already thinking this man's probably going to need a face-to-face review unless he has a good set of equipment at home. And I can feel very reassured on a video call that he's actually very stable in terms of particularly his lung function. So I will be phoning him with a view to doing a video consultation and asking him how much information he can give me remotely to help me understand which category I would put him in. And then I think the other thing to think about is the clue there was that Christine, his wife, is clearly not isolating. She's still going to work, and she has viral symptoms herself of nausea and headache. So even though she doesn't have the cough and fever, which would be typical of COVID, she clearly is a household contact of someone with suspected COVID until proven otherwise, and she therefore needs to also be self-isolating. So once we're on a video call with Barry, we can see that he's got a slightly raised respiratory rate there. He's slightly tachycardic with a heart rate of 110, and his oxygen saturations are 94. As I mentioned, he's a smoker, so it would be really helpful to see whether you've got any other documented oxygen levels from previously to see whether this represents something that's normal or abnormal for him. But certainly someone with normal lung function, he is hypoxic. He appears breathless and slightly wheezy after his exertion, and his SATs do drop after his 1 minute sit to stand test. So I'm worried about him. He's got signs of sepsis here. He's in that moderate 2A category, and I would say he certainly needs a face-to-face examination. So you might want to think about what extra can a hot hub add if someone does have their own pulse oximeter, for example. Well, the advantage would be obviously being able to, depending on the quality of your video call, to have that extra sense check that you get from face to face in terms of people's colour and whether their capillary refill. And you might also want to be listening to his chest to see whether there's audible wheeze that you might want to be treating, or creps. So I would be considering a hot hub assessment. As we've mentioned, that he's had an exertional desaturation test over the phone already. Might also want to think about some patients are very fearful of definitely going to hospital, but also even coming to a hub, especially if it's called a COVID hub, doesn't sound very appealing. In my local area, the rules are that you need to come in a car, so you need someone to be able to drive you unless you're well enough to drive yourself. And so for patients who don't have their own transport, because they're not really supposed to get taxis because of the risk of infection, passing the infection on, we do have a home visiting service, but ideally they would be able to find someone, a household contact, to bring them along. And we've mentioned that his wife should be isolating, and that we would recommend that both of them and any other household members also get COVID tested. So that is the end of the presentation. I am going to stop sharing my screen now and just say thank you very much for joining us, and I hope you found it useful.